Hello, everybody. This is Klarich coming to you from Mayo Clinic in Rochester, Minnesota. I'm here today to talk about the use of ultrasound enhancing agents in clinical practice and in the research setting. And today we have two world's experts in this area. I'll introduce Dr. Mace Ali first from Mayo Clinic, Florida. Dr. Ali is a non-invasive cardiologist with interests in diagnosing and treating structural heart disease, as well as hypertrophic cardiomyopathy and valvular heart disease. We're pretty proud of her because she's a relatively recent graduate of our cardiovascular fellowship program after completing her medical school and residency at Hopkins University. We were lucky enough to recruit her into our fellowship training program, where she was phenomenal enough that we definitely wanted to keep her on staff. Her research interests do include the safety of ultrasound and ultrasound enhancing agents. So I think it's really appropriate that we have her here to speak to us about that. And as an aside, we both teach together in the Mayo Medical School, where she's very passionate about medical education. Our other expert, many of you have already heard on this same program, is Dr. Jeremy Thaden. He's an associate professor of cardiology and practices in the division of cardiac ultrasound, where he is the clinical practice chair and also chair of quality in our practice. So I think it's obviously very appropriate for him to be here on this topic. Additionally, I think all of you know he's a phenomenal expert in structural heart disease as well as three-dimensional imaging. So I think we're in for a really interesting conversation today about ultrasound enhancing agents. I think I'll start with a question, really general question, to Dr. Thaden to start out. What are the indications for ultrasound enhancing agents, and how are you using them in your clinical practice today?
Yeah, thank you, Dr. Klarich, for the kind introduction and for the question. So we use ultrasound enhancement agent or echo contrast in a fairly conventional way. I would say the most common indication that we use it for is for endocardial border definition. So, and I think most labs would say that. So when we can't visualize two or more segments of the endocardium, we'll use ultrasound enhancement agent to better visualize. And I would say we use it in close to half of our stress echocardiograms, so probably a little bit more in the dobutamine group than in the exercise group, but overall probably close to half. And then my estimate would be probably 10 to 15%, maybe a little bit more, of our resting transthoracic studies. So again, most of those are for endocardial border definition, but it's also very useful for differentiation of masses. So we use it to look for vascular supply to masses. So helping to differentiate a tumor. I see you smiling, Dr. Klarich, because you can probably tell us a lot about that. To differentiate tumor from thrombus, which would be non-vascular. And then we are increasingly using it in TEE as well. And when we see a left atrial appendage that has thick sludge, that can kind of help us differentiate from smoke or sludge from a true thrombus. So if we see that enhancement agent reach the tip of the appendage, we know it's most likely sludge and not an organized thrombus, and that can help us differentiate which patients it's safe to cardiovert. But those would be the main indications I think that we use it for.
Well, that's great. So basically what you're telling me is you're using it really heavily in the stress echo lab for endocardial border definition to help with the identification of regional wall motion abnormalities, but it's also pretty handy for that same indication in the transthoracic practice.
Correct.
Yep. And then in addition to that, one of my passions, cardiac masses and tumors, looking for contrast enhancement of tumors to see if they have a vascular supply, which can point us in one direction or the other as a clue to whether they are malignant or thrombus. And then, or maybe even some of the myxomas will enhance, not too many of the papillary fibrillomas. Sorry for that divergence there. I diverge. But the left atrial appendage, I think I just wanted to query you a little bit more, as we do use that not infrequently in the lab to see if the whole left atrial appendage fills in. I think it can be difficult to know how long to wait, because with these patients, they have a really slow flow through the left atrial appendage. Do you have any hints, either you or Dr. Alley, on that?
When we first started doing this, we didn't have a contrast preset on our TE imaging. So I think one thing when you start is to meet with your team or meet with your representative to figure out a contrast preset for the TE, which is helpful. But I would say generally you want to, to start off, you want to turn your MI down, generally to about 0.2 or so. And then basically you want to turn the gains down and essentially image the appendage and have the appendage in view before the contrast comes. Because I can say it can be a little bit challenging to reorient yourself if you don't have that view once the contrast goes in. So I think, having your presets, having the view that you want before the contrast goes in, and then generally we give a slightly smaller dose of contrast, depending on which agent you're using. We often give about half dose initially and then redose if we need to, because sometimes you need a little bit less. But then, as you point out, it can take a while for it to actually fill the tip. So you actually have to wait. I mean, sometimes it's multiple beats and several clips to see it finally fill into the appendage. But if you do see it eventually fill, even if it's delayed, to me that suggests that it's not organized thrombus, that it's probably still sludge.
I've waited upwards of a minute or two for the appendage to completely fill, just to confirm to myself that I can actually see the tip of the appendage. And the same thing with masses. I mean, you won't see a mass enhance initially, but with vascularity, depending on the amount of vascularity, it can certainly enhance over a period of several seconds to upwards of a minute. And I would agree with the point about making sure your mechanical index is turned down, and without having a preset on the machine, knowing ahead of time at least where your MI button is and optimizing your image before you start injecting the ultrasound enhancing agent. So that really sets you up for success.
I think one of the things that I've heard from our sonographer experts who do a lot of contrast is your image, your settings should be optimized to image the contrast, not the soft tissue. So if you're doing the imaging and the mass that you want to image is already bright, then it's going to be harder to differentiate, the bright contrast from the bright mass. So really, when you start, that mass should be dark, and your image settings should be optimized for the contrast and not for the soft tissues.
I think that's extremely important point there, that you really need to optimize the images for contrast. And having that preset button is really helpful, because some of these settings on different machines, they're all over the place, and it's hard for those of us that don't use them every day to kind of remember where they are. At least that's my problem, but maybe not for those of you that are more technically advanced. But I think the bottom line is here that we use it a lot, mostly in our stress practice, but we certainly use it in transthoracic practice as well for masses and wall motion, as well as in our more newly, I would say, in our TEE practice, probably in the last 5 to 10 years, really gotten comfortable with it, especially since we now have the myocardial index or MI settings that we can adjust for TE appropriate imaging. So those are very helpful. Maybe I'll come back to you, Dr. Thaden. Who in the lab will administer the ultrasound enhancing agent or echo contrast? And I'll maybe just pause here and also make the distinction, which I meant to do in the beginning, is that ultrasound enhancing agents or echo contrast is that we're talking about today is different from the saline that we use to identify patent premenal valley. So agitated saline is a great contrast agent, but it doesn't pass through the pulmonary vascular bed. And so today we're really focusing on those commercially available agents that we actually can need to open a bottle and handle differently, which we might get into in a few minutes. But so that comes back to the question then, who is the administrator of the echo contrast agent?
So in our practice, for many years now, and certainly before I was involved in the echo lab, we've had really a sonographer-driven protocol. So we found that with appropriate protocols, that sonographers can decide who should get contrast, kind of based on the indications that we discussed, and we've found with adequate training they do an excellent job, both determining who needs it, but then administering. So in our practice, I would say the sonographers give the majority of contrast, our ultrasound enhancement agent. In our stress practice, there are some of our exercise physiologists who are involved in the stress tests who also give it, and then our nurses also give some. So we have kind of those three roles giving contrast. But in our practice, it is mostly sonographer-driven process as far as the decision and then administration of contrast.
Is that something that would be kind of uniform across the United States, do you think, and in other countries, or do you think it tends to be given by different providers in different areas?
I guess at least when I've talked to other institutions, it's been mixed. I mean, I think that there are a good number of institutions that do it the way we do it, but I think it's somewhat mixed from what I understand.
I think one of the barriers has been, historically has been reimbursement, but more recently, just who does it and how do you get that IV start that you need? That's not in the stress lab, we often have IVs because we're giving, especially in the dopamine practice, it's part of the protocol. But anyway, I think those are certainly very, very important clinical practice issues that each practice has to consider how they would fit into the workflow of starting an IV and then having someone who's really expert in administering the contrast. Dr. Alley, do you have anything else to add to that?
Yeah, I would just add that I think appropriate training is really important. And then recalling that depending on the ultrasound enhancing agent that's being used, appropriate storage. So some require refrigeration, some require mixing prior to administration. And so certainly goes beyond just being able to inject the agent. It's appropriate handling and mixing of the agent to ensure that it's done safely and that we can truly get all the images that we need.
As long as we're on the topic of safety and, training and making sure that things are done correctly, are there any potential side effects from these contrast agents, these ultrasound enhancing contrast agents that our audience should be aware of?
Yeah, so these ultrasound enhancing agents are not without potential side effects, but I think it's important to note that the majority of patients that receive these ultrasound enhancing agents do very well and they're very safe. We have seen in our retrospective review kind of more commonly seen side effects such as back pain and headache, roughly 1 in 200, I would say, a little less than 0.5%. And then patients can experience other things like flushing. We've seen things like rashes or a feeling of unsteadiness or this non-specific sensation of I just don't feel right. Those tend to be very self-limiting side effects, and patients will do well after 30 minutes or so of discontinuation of the ultrasound enhancing agent. There have been, unfortunately, some much more rare, severe, and critical adverse reactions to ultrasound enhancing agents. Luckily, these have been but less than 1 in 10,000, but we have seen patients who had loss of consciousness, loss of pulse, or ST segment elevation. And then important to note that, we categorize these. Sometimes when we think of anaphylaxis, we think, someone can't breathe, their airway gets swollen, but we've seen things like changes in heart rhythm, heart rate, that really do qualify as very severe reactions. The good news is that they are very, very infrequent, less than 1 in 10,000, but everyone needs to be aware of them.
Great. Well, I think that was a really nice and comprehensive summary. Dr. Thaden, anything else to add to that?
No, I think that's great. I mean, speaking of the back pain issue is interesting because that's one that is not serious, not life-threatening, and typically self-limiting, but can be very uncomfortable for patients, and it happens to be one of the more common ones. So there is some emerging data, and in our publication that we showed this as well, that it may actually have to do with the essentially giving some contrast agents as a bolus. So what we found was that in patients who received a bolus of contrast, they were more likely to get back pain versus patients who received in a steady state infusion. actually got more contrast, but they didn't give the bolus, they had a steady state infusion, were actually much less likely to have back pain. So that is one thing that's kind of interesting that we're exploring, and other publications have looked at this as well. There's some data to suggest that the steady state infusion may reduce the risk of back pain and some of these other self-limiting side effects.
Well, that's a really pertinent hint that you want to look, if you can, and use a steady state infusion, which I would imagine is primarily limited to those stress studies that we do, as opposed to like looking at left atrial appendage contrast. We would possibly do more of a bolus sort of a situation there, but that way we can at least mitigate in some of our patients, the vast majority, by giving them the infusion as opposed to a bolus. I think that's a great hint. And then the other thing that you both mentioned, I think Dr. Alley may want to expand upon this a little bit, is the anaphylaxis. I think I heard you say that the anaphylaxis, heart rate problems, not the typical, I can't breathe. Can you just expand upon that, or maybe reinforce some of the concepts so people will have a sense of what to do in those situations?
Yep, absolutely. So I've seen, issues, particularly, I'll use one example, bradycardia. So patients experiencing bradycardia and having really dangerously low heart rates with receiving these ultrasound enhancing agents. And so what's really important in that particular case is ensuring that you have an appropriately trained team and that you have medications on hand, things like epinephrine, things like atropine. Essentially, if you have to run a code on a patient because they are profoundly bradycardic or you've had loss of pulse, we don't think of these in the traditional sense of anaphylaxis, perhaps, but these are very severe reactions that patients have had. And this is, in my viewpoint, honestly, a contraindication to patient receiving any of that similar ultrasound enhancing agent moving forward.
So would you start out obviously with the atropine to try to bring their pulse rate up, possibly, if it's very severe, you might be in a code situation, as you alluded to. But are there other tools that you would use? I think about anaphylaxis, would you use Solumedrol, prednisone, would it be Benadryl, those types of things that you'd throw into the mix there?
Yeah, I think that the most critical thing, certainly there may be a little bit of like a mast cell activation where there's a big histamine overdrive, but I think of this as really being an effect on the electrical system of the heart. And so really using agents like epinephrine, I think would be one of my first go-tos. And I don't know if Dr. Thaden, if you have additional thoughts.
So we have kind of protocolized the response. So we have this for anaphylaxis or anaphylactoid type reactions. And so with any anaphylactic reaction, epinephrine, antihistamines, and steroids are all considered important. For some of the reactions that we've seen more recently, in particular, have not really involved, typical. Patients haven't had, urticaria. They haven't had hives. They haven't had bronchospasm. They haven't had the typical anaphylactic type reactions, anaphylactic type signs or symptoms. And so if a patient has primarily bradycardia, for instance, we've seen patients with symptomatic bradycardia soon after contrast administration. In a case like that, I think it's reasonable to give atropine if you have it. But then understandably having a very short, a low threshold, I should say, to give epinephrine and kind of all of these other medications if the patient remains severely symptomatic. So I think it's a mixed bag, I think, potentially depending on what the patient presents with as far as symptoms, but definitely would have a very low threshold to treat with epinephrine, antihistamines, and steroids for anaphylaxis.
Although the ultrasound contrast agents, ultrasound enhancing agents are relatively safe. 1 in 10,000 serious, reactions. Maybe 1 in, 200 to 500?
Roughly 200.
Might have a, significant backache or headache, or maybe just some unusual symptoms, kind of non-specific. So we can feel pretty assured that not only can we use them with great safety, but we have pretty effective therapies to treat the reactions that they would have, and we shouldn't withhold contrast if we think it would enhance the study. However, when someone does have a reaction, then we should write it down as a allergy to that specific agent, is what I think I heard you said, Dr. Alley. Would you say you could use another contrast agent, potentially a different, because we know there's several available?
Yeah, we've seen, our patients have had a severe reaction to one agent, but then tolerated another agent well. So I think you need to be cautious using additional agents, but as long as you're appropriately monitoring the patient, I would say, they all have different gases and microsphere and shells. And so whether there's some cross-reactivity is maybe a little bit unclear. We don't have as much data. So I would be more cautious, but I wouldn't let a reaction to one agent preclude me from using another one in the future. Dr. Thaden, if you feel similarly.
Yeah, and this is so this is and also an area that's a little bit unknown, and this is kind of where our allergy colleagues can kind of add. So I think these patients ideally should be referred to allergy for additional evaluation. Now, there's some workup that can be done acutely to see whether it's an anaphylactic reaction. But then the follow-up, because one of the things that has gotten a lot of attention is polyethylene glycol. So the available agents that today, except for one, so two of the three have polyethylene glycol. And so there's some of these patients, perhaps not all, but some of these patients could be reacting to the polyethylene glycol in the agent. So 2 out of 3 of the agents have it. It's incorporated into the contrast agent in a slightly different way for each. But this is where allergy can help us. Is there a specific component of the ultrasound enhancement agent that's that the patient is reacting to, because if it's the polyethylene glycol, then there's an alternative agent for that particular one. We would choose Optison. So Optison is the one agent on the market that doesn't have polyethylene glycol in it, and so it would be a good option for those types of patients.
That's very interesting, and it sort of talks to the fact that we sort of lump contrast reactions into all contrast agents, but there may be some variation amongst contrast agents rather than just saying that they're all good or they're all bad in a certain patient because they had a secondary effect. And then one of the other questions that comes up is if a person does have, the backache, headache, one of the more sort of non-specific kind of mild symptoms, would that patient then go on to possibly develop more serious symptoms with further administration of those contrast agents? Or do we even know that?
Yeah, so we think that those reactions are unrelated. So we think that the backache, headache, the backache in particular, we think is from a potentially accumulation of the contrast agent, the bubbles within the renal vasculature. And so we think that those are essentially completely unrelated. So we don't think that patients who have back pain are likely to develop serious adverse reactions. And I think of, personally, I think of the back pain as a relative contraindication because we don't think of it as a dangerous reaction. But I think this also speaks to having the option for more than one, having the expertise to administer more than one contrast agent in your own lab is helpful for when this comes up. So that's another thing I think I would advocate for most labs, even if you have a primary agent that your lab likes, to have a second agent available as another option for those patients who have reacted to a contrast agent in the past.
Well, that's fascinating. Dr. Alley, do you have anything else to add?
No, I think Dr. Thaden summarized that well.
Well, this has been a really fascinating conversation about echo enhancing agents, primarily the IV administered. I guess even the agitated saline is IV administered, but the commercial agents that we use for primarily endocardial border definition. Currently, in our own practice, half of our patients are getting that in general for stress testing, and another 10 to 15% for routine transthoracics. And then we have the sort of kind of niche things looking for thrombus in the left atrial appendage when you're in the presence of sludge. And then the last thing would be tumors. The side effects are by and large quite rare, but we could choose a different agent even for mild side effects if we have that capability within our lab. And lastly, the serious adverse side effects or serious adverse reactions would be treated like an anaphylaxis, treating first the rhythm issues, which usually are bradycardia, but then escalating that to steroids and antihistamines in order to, and then at that point in time, we tell that patient that particular contrast agent, and maybe if it was the perfluoral glycols, what can you say that again?
Polyethylene glycol.
Yeah.
Thank you, polyethylene glycols. Then we would probably steer clear of those if we needed contrast down the road.
Yeah.
So I think this has been a really very deep and very helpful conversation to an area that's evolving. And thank you both for your active research and leadership in this field. Thank you for taking time out of your very busy clinical practices to join us, and appreciate the multidisciplinary approach here today too.